course of action. And I'm very concerned about how the VA has interpreted and differentiated between institutional and uninstitutional extended care. It is becoming increasingly clear that once again, bureaucracy has overcome intent. VA continually repeats that there is no wrong door for veterans seeking substance abuse care. However, we will hear from our witnesses on the second panel that that is inaccurate and bureaucratic hyperbole with that statement. I'd like to point out 3 instances where the VA has not embodied their no wrong door declaration. First, we have heard from a specific veteran who struggles with PTSD and alcohol abuse. After many attempts and 3 months of trying to receive care, this veteran was not able to get the help they needed. This was essentially a locked door. This veteran spoke with multiple congressional offices and with the VA central office. They were eventually referred to community care. However, it was rescinded as the VA ensured that this veteran could receive the care they need. This veteran still struggles with their sobriety today. Next is an example of the VA presenting no door to a veteran. As we will hear during our second panel, there is another instance where a veteran sought care in the community. However, VA noted that they could not refer this veteran into the community if a VA bed was available within 30 days. Veterans can and should not have to wait 30 days to receive care that they desperately need. The program attempting to assist this veteran was told that veterans must first go to domiciliary, then grant per diem programs such as VA homeless shelter, and then to the Salvation Army. Then, after all of these options have been exhausted, they could be referred into the community. That's a disgrace. And as a state senator, I specifically introduced legislation to get rid of pre-authorization for medicated-assisted treatment, so within immediate. So to find that this is existing with our VA system is unacceptable. Finally, we have heard from a veteran who has struggled with PTSD, substance use disorder, and a history of traumatic brain injury. This specific veteran was searching for a residential program for substance use disorder at the VA. However, this veteran was denied because they did not have a history of seeking help through the VA. Because this veteran had not been to the VA since 2017, their record was closed, and they were never contacted about receiving care. This appears to be a case where a veteran experienced a missing door. Luckily, a VSO paid for a treatment program for this veteran. There is no excuse for any of the neglectful and harmful care that these veterans are experiencing, and we need to hold the VA to a much higher standard. I'm saddened and I'm frustrated that this is how VA has been managing care for those who have selflessly served our country. Thank you all for being here, and I look forward to our discussion on both panels to best identify ways to improve access. With that, I yield to Ranking Member Brownlee for an opening statement.
Thank you, Madam Chair, for holding this morning's important hearing. As of fiscal year 2022, more than 550,000 veterans receiving VA health care, or about 8.5% of all veterans using VA health care services, had substance use disorder diagnoses. Often, veterans have turned to alcohol or drugs to try to relieve stress or symptoms of PTSD and other co-occurring mental health disorders. As a result, substance use disorder is a significant challenge among the veteran population. This challenge was only compounded by the COVID-19 pandemic, which increased feelings of social isolation, anxiety, and depression, and caused many adults to start or increase their use of alcohol or drugs. At the same time, access to intensive residential treatment at VA and in the community declined as providers limited admissions and placed residents in single occupancy rooms in an effort to minimize the spread of COVID-19. I am perplexed by the 2 very different stories that were told in the written testimony of VA and the other witnesses we will hear from today. If we are to take VA at its word, veterans receive timely access to residential treatment, admission within 72 hours for veterans requiring priority admissions, and within 30 days for routine admission. The VA Office of the Inspector General, however, has found that VA, quote, faces significant challenges in meeting the needs of individuals with substance use disorders, end quote. This finding is echoed in the testimony of our second panel of witnesses, and I hope today's hearing will help us better understand the true state of veterans' access to residential treatment for substance use disorder. I do not doubt that there are instances where veterans would benefit from referral to residential treatment from community providers, particularly when there are excessive wait times for beds in VA programs or when veterans can access timely care in the community closer to home. However, we must ensure that veterans receive high-quality, evidence-based care when they are sent to the community. I hope today's hearing will also shed some light on the extent to which VA ensures that the community providers to which it refers veterans meet clinical practice guidelines and accreditation standards for delivering such care. While we will focus much of our attention today on access to residential treatment, I hope we will also take some time to consider the full continuum of care, including the extent to which veterans are successfully transitioning from residential care to outpatient treatment and independent living. As the VA Office of Inspector General points out in its testimony, care coordination between VA and community providers is critically important for high-risk patients like those receiving treatment for substance use disorder. When patients receive care in the community, they are not always as easily able to access other VA benefits, such as housing and employment support, as they would if receiving care at a VA facility. In 2019, I visited a truly impressive program operated by the VA Boston healthcare system called the Women's Veterans Trust House, which provides excellent care, coordination, and continuity of care for women veterans who had completed residential treatment for substance use and post-traumatic stress. The typical stay is about 12 months, during which time women veterans participate in individual and group psychotherapy, compensated work therapy, and recreational community outings. Through this program, they are learning how to develop healthier coping mechanisms and constructive interpersonal relationships. Unfortunately, at the time I visited, the Trust House could accommodate just 7 women at a time, and they were traveling from all over the country, first to participate in VA's residential treatment program and then this transitional program. Undoubtedly, more women veterans, indeed all veterans, would benefit from greater access to transitional programs like this. I hope that we can learn more today about the extent to which VA is trying to expand its capacity in this area as well. I have legislation that aims to do just that, and I hope today's hearing will help inform my planned reintroduction of the bill. Thank you again, Dr. Miller-Meeks, for organizing this important hearing, and I yield back.
Thank you, Ranking Member Brownlee. I'd now like to introduce the witnesses. Joining us today from the Department of Veterans Affairs is Dr. Tamara Campbell, who is the Executive Director of the Office of Mental Health and Suicide Prevention. Accompanying Dr. Campbell today is Dr. Sashin Yindi, I apologize for any mispronunciation, the Chief Medical Officer in the Office of Integrated Care. We also have Dr. Julie Kroviak, the Principal Deputy Assistant Inspector General of Healthcare Inspections in the Office of the Inspector General. Dr. Campbell, you are now recognized for 5 minutes to deliver your opening statement.
Good morning, Chairman Miller-Meeks, Ranking Member Brownlee, and distinguished members of the subcommittee. Thank you for the opportunity to discuss VA's mental health, substance use disorder, residential rehabilitation treatment programs, and community care referrals. Accompanying me today, as mentioned, is Dr. Sashin Yindi, Chief Medical Officer, Office of Integrated Veteran Care. Over the past decade, potent and dangerous drugs became more widely available and misused in the United States. In response to the rise in substance use morbidity and mortality, prevention and treatment efforts have been established. VA is making a positive difference in veterans' quality of life by enhancing motivation and building confidence in their treatment and recovery process. Veterans receiving treatment for their substance use disorder in VA are experiencing benefits in terms of their mental and physical health across many other aspects of their lives that impact social determinants of health. VA's mental health RRTPs are a critical component of VA's broader efforts to address the needs of veterans with substance use concerns. Mental health residential programs are institutional extended care and are not subject to designated access standards. They do, however, have access requirements that inform when consideration for referral to the community should occur. These access requirements are defined by VHA Directive 116202 and more recently by implementation of the Compact Act for Crisis Residential Care. The ability to pay for community care mental health residential treatment has resulted in an increase in the number of programs available to veterans. From fiscal year 2021 to fiscal year 2022, referrals to the community increased from 7,000 to 11,000 uniques, with expenditures exceeding $1.2 billion since 2021. Concurrent with these increases, VHA has observed instances of community programs marketing directly to veterans and providers, resulting in confusion by veterans when informed of the availability of VHA to meet their needs. We believe the solution to this lies with increasing familiarity with the process and with VA's mental health residential resources, while also addressing concerning marketing practices when they are identified. Timely access to residential treatment has been a priority area of focus for VHA. This has been critical as the residential programs experienced significant reductions in capacity early in the pandemic. I'm pleased to share that today, MHRRTP capacity is rebounding with wait times decreasing and census increasing. Recognizing a need to ensure access to this critical level of care, OMHSP worked collaboratively with the Office of Integrated Veteran Care to verify authority to provide residential treatment in the community and to provide a mechanism by which VHA could pay for such care. VHA policy requires that when a veteran is assessed as requiring residential treatment and the program is unable to meet the veteran's needs, an alternate treatment program must be offered. Alternate treatment may include treatment within VA or within the community. VA is thankful for the independent investigation of the Office of Inspector General in the review of the domiciliary sub-treatment program and residential community care referrals. The ability to refer to mental health residential treatment in the community is a relatively new process, with the first standard episode of care for the mental health residential treatment released in October of 2020 and updated in August of 2021. OMHSP worked collaboratively with VISNs during this time to clarify requirements and expectations for when referrals for mental health residential care in the community may occur. These efforts have continued with targeted efforts to ensure awareness of requirements and processes for ensuring access to residential treatment in the community when indicated. In conclusion, we appreciate the committee's continued support and partnership in this shared mission. Nothing is more important to VA than supporting the health and well-being of our veterans and their families. This critical work is life-saving, and my colleagues and I are now prepared to respond to any questions you may have. Thank you.
Thank you, Dr. Campbell. Dr. Kroviak, you are now recognized for 5 minutes to deliver your opening remarks.
Thank you. Ranking Member Brownlee and subcommittee members, thank you for the opportunity to discuss the OIG's oversight of VHA's substance use disorder treatment program. The OIG's Office of Healthcare Inspections reviews the quality and safety of healthcare provided across VHA and communicates the findings through public reports. We are unique in the IG community because of our ability to conduct this oversight. With over 250 clinical staff, the majority having significant experience providing direct care to veterans, our reports can provide in-depth clinical analyses and identify issues that impact healthcare delivery. Take our mental health team, staff with board-certified psychiatrists, psychologists, and licensed clinical social workers. They are proactive and vigilant in conducting oversight work that supports veterans in need of mental health treatment. We are in the last stages of developing a new cyclical review that will initially focus on VHA's inpatient mental health units. These units treat acutely ill psychiatric patients, and our teams have developed tools to evaluate the safety and efficacy of these settings to ensure veterans are receiving the high-quality care they need and deserve. Substance use disorders have devastating effects on veterans, their families, and caregivers, and often require intensive multidisciplinary interventions to support a meaningful recovery. In addition, veterans with substance use disorders often have additional mental health diagnoses that can place them at higher risk for suicide. Given that VHA's top clinical priority is to reduce veteran suicide, evidence-based substance use disorder treatment programs are critical to addressing these clinical needs. To meet the increasing demand for these services, VHA depends on community care. When VHA and community care providers are co-managing these patients, the coordination must be seamless and collaborative. The OIG has identified persistent administrative errors and communication failures among VHA, its third-party administrators, and community care providers, as well as between the care providers and their patients. These deficiencies challenge the efforts of VHA personnel to ensure that seamless experience for veterans. Many OIG reports have described the challenges and, most importantly, the risks when patients are referred to the community. These risks are amplified for patients with high-risk mental health issues or complex disease. For example, my written statement details our January 2023 hotline inspection that substantiated the allegation that in 2020 and 2021, VA North Texas staff did not follow VHA policy requiring that patients be offered alternative options for care within VHA or the community when the wait time for a needed service exceeds 30 days. This practice potentially delayed treatment for these veterans and has the long-term potential to fracture trust between patients and the healthcare system upon which they rely. We also determined that the VISN's chief mental health officer lacked authority to ensure staff adherence to these policies. We made 5 recommendations, with one specifically ensuring that staff comply with community care referral requirements, and another recommending a review of the facility's management of community residential care referrals. All of these recommendations are open, and we will begin the follow-up process with VHA at the end of this month. While this report highlights issues with offering community care to veterans, it does not provide a complete picture of the concerns we have found when veterans are receiving community care. Our office has published reports related to community care detailing delays in diagnosis and treatment, lack of information sharing or miscommunication between providers, and significant quality of care concerns. While we recognize the importance of VHA staff consistently informing and offering veterans all options available to meet their care needs, ignoring that the current community care framework does not adequately address critical gaps in coordination will further increase risk to patients. We are piloting a new community care review that will provide data to support VHA's leaders' efforts to reduce these risks. The OIG will continue to provide meaningful oversight to support and improve the quality of health care provided to our nation's veterans. We also recognize the need to enhance and adapt our work to best support this dynamic healthcare system. We remain grateful for the participation and cooperation of VHA staff across the country, and we commend their commitment to caring for those who have served. Members of the subcommittee, this concludes my statement. I would be happy to answer any questions you may have.
Thank you, Dr. Kroviak. We will now proceed to questioning. I now recognize the Ranking Member Brownlee, for any questions she may have.
Thank you, Mr. Chairman. The first question I have is to Dr. Campbell, and I understand VA currently has 2 dedicated residential substance use disorder treatment programs for women veterans. Is that correct? 2?
I didn't hear, I'm sorry, the first part of the question.
I understand that VA currently has 2 dedicated residential substance use disorder treatment programs for women veterans. Is that true?
We have 13 programs across 9 locations specializing in treatment for women at the residential level.
And I had difficulty finding those. Where do I go to
So
find those?
they're on, you can locate them on our website, and they are in VISN 1, 10, and I believe 17.
So I understand that all of these aren't substance use disorder treatment programs.
There is a mixture, and thank you for that question, of substance use disorder as well as PTSD. We understand that those diagnoses typically coexist, and so we ensure that our programs are treating both the PTSD and substance use at the same time.
But just to get back to my original question, is there currently 2 dedicated residential substance use disorder treatment programs for women veterans? True or false?
I would have to go back to get that exact number. What I have is 13 programs across 9 locations, 5 programs such specifically focused, and 2 additional that are in for implementation for fiscal year 2024.
Okay. I also understand in the fiscal year 2024 budget request indicates that the department has 2 additional women-only residential programs in development. Is that correct?
Yes, ma'am, that is correct.
And in what locations will they be?
I will have to get back about those locations.
How did you decide where the locations should go?
We are in the process now of making that determination.
So in my opening comments, I talked about transitional programs and the continuity of care for our patients. Does the VA, I know today we're focusing much more on intensive residential treatment, but wanted to know how many transitional programs across the VA do exist. I mentioned 1 in Boston.
So we have, thank you for that question, and I would have to get back with you about the specific numbers. But we, in terms of transitional programs, we have compensated work therapy and community reentry programs within all of our domiciliary programming. Is that what you're referring to?
Yeah, yes. I mean, for those kinds of services, but in a transitional, in a transitional space environment, where women would be co-located, going through with these particular kinds of services offered to them. The one I referenced in Boston lasted for almost a year, so of transition. So. That's what I'm looking for. But apparently, we don't have the answers to that, and I'll have to wait until you can get back to me on several of these questions about numbers of residential treatments for women, and the 2 additional women clinics, where they are and how they were decided upon in terms of location. So my last question to Dr. Kroviak, so in terms of veterans being referred to in the community, what are some of the hallmarks of quality residential substance use disorder treatment programs, and how does coordinating this kind of care in the community differ from coordinating a medical procedure, such as surgery?
So there are some accrediting bodies that are important to the residential programs like CARF or Joint Commission. So VA is required to ensure that when they are referring a patient to this type of treatment, that those facilities are certified by one of the 2 institutions as well as the state in which they're operating. And in terms of referrals, the referral process is quite similar. A patient can self-refer. Any provider can refer a patient when they are appropriate and engaged in that level of care.
So just this accreditation process or, approval from these outside agencies, and as far as you're concerned, the VA is adhering to those requirements?
We have no concerns that VHA is not, meaning that we haven't heard allegations on that front, and those are appropriate accrediting standards to ensure.
Thank you, and I yield back, Mr. Chairman.
Thank you, Ranking Member. The chair recognizes Congresswoman Kiggins.
Thank you, Mr. Chair, and thank you, committee members, just for being here, our board members. Just a question about about reimbursement for community care providers. We got to hear from them and just some of their struggles with why are they not accepting some of our patients that we're referring to. They had concerns about their reimbursement rates and about the time it was taking for them to be reimbursed. Can you tell how competitive we are when looking at community care compared to the VA system? Is the compensation competitive, or do we look at that even when we're thinking about compensation?
Thank you for that question, Congresswoman. In terms of processing claims, in general, VA has been pretty good about processing clean claims. I believe over 95% of these clean claims are processed within 30 days. I don't have the exact numbers for RRTP programs, but we can get back to you if needed. In terms of a reimbursement, we follow Medicare rates in general, but there are lots of nuances about reimbursement. I believe we are competitive, but if there are specific questions about a particular CPT code or those kind of details, we are happy to work offline and try to clarify those questions.
There's just a comment that I've heard more than once about why they can't take VA or they don't want to contract with the VA because our reimbursement rates weren't competitive for them. And there's such a shortage of mental health providers in the community and a VA throughout the country that, I just want to make sure we're prioritizing staying competitive so that they are incentivized to be able to see our patients. And so I represent Hampton Roads and recently got to talk to and visit the Hampton VA, which is doing a great job. Their two complaints were that they wanted more space and they needed more people, which I think is kind of our universal complaints. But their mental health department, I think they're doing good work. And overall, I just want to say thank you, to them. I know it's a hard job. I know that as a nurse practitioner, I know nurses especially have been asked to do a lot during the pandemic, especially in the mental health field and all providers. So I want to thank them because they are doing good work out there. One of the things I hear about and that I'm concerned about as well is when we have these great inpatient programs that we send our veterans to for substance abuse, for any mental health as depression, anxiety, suicidal ideations, we stabilize them and have them there for however long it takes, and then we release them back to the community, back to their homes. And that continuity of care piece, you guys talked about it a little bit, but we see it, I saw it, in my practice, it's like we lose them to the community, right? So how are we ensuring that when these patients are discharged, I'm sure there's a discharge planner that makes sure they have a follow-up appointment, that makes sure they go home with their meds. On the State House level, I know we were pushing for things like home health to actually visit the home, because leaving the motivation just with this patient and they're already probably struggling in their family and a lot of questions, new side effects of medication, transportation issues, all those things. So my desire was to have someone actually visit the home. There's so much benefit. We can get to see what that home environment looks like. So that continuity of care piece, whatever that looks like, is it home health? Is it, what is the VA doing to just ensure that, is it utilization of nurse managers, to make sure that we are really thinking of all the issues that veterans struggle with once we get them stabilized so that we don't lose them to the community?
Thank you for that question. And we do have full comprehensive continuum of care that includes, as we mentioned, inpatient, which is the most restrictive, all the way to outpatient services, as well as leveraging our peer specialists and that provide a lot of coaching. The uniqueness about VA peer specialists is that they have a veteran lived experience. And so they're able to rapidly build rapport with our veterans. We certainly are able to leverage telehealth services so that when the veteran reintegrates in the community and is competitively employed, we can utilize that service so they don't have to spend time away from a job that they've been newly employed to. And then we have multiple award-winning apps that can be downloaded for the veterans' use. Thank you.
And they're utilizing those things. Someone is going behind them and making sure they're utilizing one of those great services.
Yes, we are.
Thank you. Thank you. I yield back.
Thank you. Congresswoman Bazinski, you are recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you, Ranking Member. And thank you to the panel for being here today. I represent a predominantly rural district in central and southern Illinois. I just got back from a 2-week recess working at home in district and heard from many of the veterans while I was in district that are struggling still in accessing VA services, specifically in our rural areas. This is very concerning to me as the rate of veterans with substance use disorders continues to climb, especially post-pandemic. Rural vets simply don't have the access to as many SUD treatment programs and facilities as they do in urban areas. So my first question is really two-part, and it's for Dr. Campbell. What are the steps the VA is taking to ensure rural veterans with substance use disorders are able to access high-quality VA treatment programs, and what is being done to address the infrastructure and access shortages for our rural vets?
Thank you for that question. We do realize that that is a challenge for our rural veterans. Whenever we can, we leverage our telehealth services. Sometimes we know that there could be bandwidth problems with that. Veterans are still able, certainly, to see individuals face-to-face as needed. The Office of Mental Health and Suicide Prevention has partnered with Rural Health and our clinical pharmacy service to help us leverage additional prescribers for medication-assisted treatment for our veterans.
Thank you. I wanted to add on to what Ranking Member Brownlee had just asked about some of our women veterans in particular. As you know, the number of women in the military is increasing, and women are the fastest growing demographic within the VHA. It's why within my district I'm going to be specifically assembling a Women's Veterans Council so I can hear specifically from the women veterans in the district. Because female veterans are experiencing many of the same problems as males, but there is emerging evidence showing that women veterans may be more likely to experience substance use disorders than their male counterparts. This is due to additional factors for women veterans tending to experience such as higher chances of experiencing sexual assault and harassment, rape, and intimate partner violence. So again, my question is for Dr. Campbell. The VA has acknowledged it needs to improve VA services for women veterans, but what are some specific steps that the VA is taking to improve and expand specialized care for women veterans experiencing substance use disorders?
Thank you again for that question. Wherever we can, in terms of our full continuum of treatment, we are making sure that those individuals who are specialized to address women's health needs are right in those clinics, such as the primary care mental health integration clinics, certainly on our residential treatment programming clinics. And then we are also ensuring that that our women's advocacy is shored up, that they have the time to devote to make sure that there is seamless flow of treatment for women within VA.
Okay, thank you. And since I have a little bit more time, I'm actually going to shift to residential rehabilitation treatments. And to just note, I understand some of the concerns my colleagues have voiced regarding access standards for residential SUD treatment, as this can lead to longer wait times and longer travel times for our vets, which I know we've been talking about. The ability to have all levels of SUD treatment available, including outpatient, residential, and hospital inpatient services, is still strained for all veterans, however, more so, again, concerning for women veterans and for rural veterans. I also understand that we need to ensure our veterans have protections from fraudulent community providers who have taken advantage of vulnerable patients seeking treatment and who have prioritized profits over the safety of their patients. Veterans deserve, as I believe, high-quality, evidence-based care if they are sent to community providers for sub-treatment. So, Dr. Campbell, I know not all veterans have a substance use, require a substance use disorder residential treatment, but for those who do, How can the VA help to ensure those veterans are able to access the intensive SUD care they need while also making sure they are protected from fraudulent providers or entities? Thank you.
So thank you again for that question. We are in the process of continuing to educate within our own organization and certainly with the community, the standards that we expect in terms of particularly SUD treatment. And so we have completed regional conferences to make sure that our staff is aware of the policies as it pertains to community care, as well as holding quarterly meeting with our VSO stakeholders to make sure that they understand where our programs are and to listen and learn regarding the concerns they have. And I wanted to mention another certainly concern of our women veterans is that they need to feel safe when they come to our facilities. And so within our residential units, we have secured wings just for our female veterans with closed-circuit TV monitoring at exit entrances so that we can keep monitoring as closely as we can. And Dr. Yindi can.
And just to add to Dr. Campbell's point, from a community care side, in addition to the accreditation requirements that Dr. Kroviak mentioned, we also have standardized processes where our TPAs are expected to review LEIE list. So if a provider has engaged in fraudulent activities and that has been confirmed, they will be part of their LEIE list and they are expected to be excluded from that
Thank you. I think we're over time. Thank you for your generosity, Madam Chair.
Thank you. The chair now recognizes Representative Luttrell for 5 minutes.
Thank you, Madam Chairman. Dr. Campbell, I understand. I'm going to go off what the ranking member asks. And so the VA currently has 2 dedicated residential substance use disorder treatment programs for women veterans. And then the question was asked, there's 2 additional residential programs in development. Where are they? And are they admitting patients? How did the VA decide on these location programs? Because the budget itself is already out. And I do respect and appreciate the weight that you have to carry, but we have to go back to our district, and when these questions come for our constituents, and the fact that you weren't able to answer those questions in front of us today is disheartening, because now we have to go back and tell them that the VA doesn't know. So, can you want to respond to that?
I would, and thank you again for that question. I certainly understand the responsibility that we all have to our veterans for these answers. I will certainly get that answer to you as quickly as I can regarding where the 2 additional programs will be located. The other programs that I mentioned specific to women are in VISN 1, 10, and 17. I will check that, though, to make sure that that's accurate.
Thank you, Doctor. I appreciate it. Dr. Kroviak, are you familiar with VHA Policy 1162.02 regarding mental health residential rehabilitation treatment programs?
I am somewhat familiar. I certainly didn't draft it, but I'd happy to take your question.
What do you know about it? Give me the wave top.
I'm sorry?
Can you give me what the wave top description is, the way you think that is?
The referral time, you mean?
Oh, well, I'll get in. I'll just go this way. So it states, the directive states that any veteran with a scheduled wait time of greater than 30 calendar days must be offered alternative residential treatments on another level of care to meet the veteran's needs and preferences at the time of screening. Where did 30 days come from?
That was legislated, to my understanding.
Do you think that that is a good...
Oh, I'm sorry. I might be confusing with the Mission Act. I think the 30 days was just a metric developed to assess progress towards providing the care that wasn't available.
So given the issues that we see in suicide and substance abuse, the psychiatrists and psychologists and doctors in the VA still think 30 days is a reasonable time frame?
I would have to defer that question to VHA in terms of the 30-day standard of what their providers assume is appropriate.
As the Inspector General, haven't you, I would assume that you would dig into this problem.
In terms of the 30-day standard, that wasn't established by the IG. We would just do oversight to hold
I guess my question
VHA
is, do you
accountable.
think that that time frame is too long?
I think it depends on the diagnosis that you're describing. I think it's a clinical decision. I think 30 days is somewhat arbitrary for a lot of these issues that veterans are referred for specialty care.
Some don't like the Community Care Network. However, the intent of the new Compact Act is to provide immediate access to those services anytime, anywhere, largely expanding access to community care. What is the view of the VA on implementing the Compact Act? Is there any rulemaking to write directives and policy to implement the act itself?
Thank you for that question. So Compact has been implemented. As you mentioned, that it allows the veteran to be treated for an acute suicide episode at any community facility or within VA. And I will defer to Dr. Yendi for more information on Compact.
Congressman, implementation started in January of this year. Implementation of the Compact Act started in January of this year. And to date, we have provided care for over 11,000 veterans since the program started.
11,000?
Yes. And this is both on the direct care side as well as on the community care side.
Okay. Final question. I'm just going to throw this out to the three of you. Are any of you aware of a new VA community care policy or process and or guidance within the last 10 months surrounding mental health residential rehabilitation treatment program that restricts, inhibits, or deters community care referrals? I say that because I actually have verbal and written statements by VA employees that state that they are under this new policy.
To our knowledge, Congressman, we have no policies that would restrict. If they meet criteria for referring the patient to alternative treatment facilities for our RTP programs, which includes community care, they should be referred in a timely manner.
My time's up, ma'am. I'd like to reserve the opportunity to submit additional questions.
So recognized. The chair now recognizes Representative Landsman for 5 minutes.
Thank you, Madam Chair, and thank you all for being here. My district, which includes the city of Cincinnati, Southwest Ohio, is home to a great VA. And we offer, some of the best veterans care in the country for PTSD, suicide prevention, and other mental health issues. And when I've spent time with folks at the VA in Cincinnati, they talk a lot about the evidence-based programming, and it's really compelling. When it comes to specialty treatment for substance use disorder, veterans across the country aren't getting the care they deserve. This may have already come up, but I have seen statistics that suggest more than 550,000 veterans diagnosed with substance use disorder. Last year, of those, 62% received outpatient treatment, but those numbers drop off drastically as the level of services increase. So less than 25% received specialty care, and even fewer received intensive care at 4%. So you see there's this drop-off in terms of if a veteran needs additional treatment outside of the outpatient treatment. So I have two questions. One has to do with, do you have a sense as to the drop-off? What do you know? Have you seen? Is it staffing? Is it other issues? And then the second has to do with a general question as it relates to all of the VA services. And this is true for a lot of public services, nonprofit services, and that is that we really do struggle to get to folks who aren't getting to us. And this is particularly true for veterans, particularly veterans who are just not coming in, and have real issues. So I have been pushing in these hearings for the kind of programming outreach that gets the VA to where folks are. And so I'm curious what you think has worked, could work, in terms of meeting veterans where they are and connecting those who are currently disconnected. So 2 questions. One has to do with the drop-off and the second, outreach. Thank you.
Thank you, sir, for those questions. And so I'll take the first question in terms of the dropout. So the dropout may not necessarily mean that that veteran isn't in some type of other care. And I think what you were referring to is a drop-off when it concerns more intense care, such as residential treatment. So the veteran may still be involved in an outpatient treatment, may be involved with teleservices, and sometimes for various reasons, the veteran has elected a later date to come into treatment. So that decision regarding the level of care is always between that individual veteran, patient, and the provider that's helping with the medical disposition and clinical decision-making. But we do realize, especially where community care is concerned, because SUD is such a specialized treatment, that it may not be available in every location where that veteran is. And in terms of your second question regarding being able to touch veterans who aren't already in our care, we are certainly hoping that the legislation that's been passed with Compact, allowing veterans to be treated wherever the need is without any cost to them will help with that. We have fantastic media campaigns, Don't Rate, Reach Out, where we are utilizing veterans to help veterans understand what it's like to come into VA for care, and then certainly leveraging everywhere we can our peer support specialists who have that lived experience that can help us bring in care.
Thank you very much. And I have additional questions if I can submit them. Thank you.
Dr. Campbell, good afternoon. How long has your office been in existence? I know you've been there since 2022, but how long has the Office of Mental Health and Suicide Prevention been in existence?
I'm sorry, sir, I didn't hear the entire.
How long has the Office of Mental Health and Suicide Prevention been in existence?
Been in existence. Been in existence. At least 30, 40 years.
34 years, very well, thank you. How many people work for you?
I have about 140 people within my office.
Got it, thank you. Do your reporting numbers reflect, for veteran suicide, do they reflect overdoses?
That is a separate report in terms of overdoses that we hope to be able to publish the end of June.
So in your opinion, doctor, if someone kills themselves by overdose or gunshot wound, are they still dead?
They are still dead, sir.
Okay, so do your metrics for veteran suicide include overdose?
The metrics that we reported recently on our annual report does not include overdose.
Okay, that's a problem. What are your established metrics of success for your Office of Mental Health and Suicide Prevention?
So we have various metrics depending on the service that we're looking at in terms of outcomes. So we have hundreds of metrics that we use. It depends on specifically what you're asking about in terms of outcome.
Do you think, and please take this as it's intended, Morgan and I have had multiple friends commit suicide, over 21 now for me personally. Veterans have committed suicide. So do your metrics include veterans that don't commit suicide? And I know it's kind of hard to prove a negative, but what I'm wondering is, after 34 years of existence with over 140 employees, if your office ceased to exist, would more veterans be alive tomorrow. I mean, is your office preventing veterans from committing suicide or not? Or are we just spending money and hiring people so that they can get together, come to these committee meetings, talk a bunch, submit reports, metrics that can't be defined? Are you moving the needle?
Sir, we do, and thank you for that question. I certainly can understand the frustration. This is a very complicated area. We are certainly ourselves saddened by any
Doctor, please,
suicide.
I have a limited amount of
I do believe we are moving the needle on this. We have a full public health approach where suicide prevention is concerned. And the field of mental health and psychiatry has evolved over the past 30 to 40 years. And so as we continue to evolve, we are learning new things, new methods, new evidence-based approaches that we can use.
Thank you. And that leads to my next question. How many non-evidence-based treatment modalities do you guys support, specifically religious and faith-based programs similar to the incredibly successful Mighty Oaks Foundation? How many faith-based non-evidence programs are currently being administered by the Veterans Administration?
Thank you again for that question. Within VA, we certainly value scientifically based, evidence-based programs. That does not mean, however, that we don't collaborate with our chaplain services that certainly help us with specifically the moral injury side of PTSD and other mental health disorders.
So, Doctor, what I'm hearing from you is that the Veterans Administration is not helping these wildly successful programs that can quantify, like actually quantify the amount of veterans' lives that they're saving because they're faith-based, which according to you guys are non-evidence-based. Living veterans, that's evidence of a program's functioning. So I just want to be real clear. You're telling me the Veterans Administration is not allowing non-evidence-based, specifically faith-based programs like the incredibly successful Mighty Oaks Warrior Foundation to function within your organization, even though they've proven to save thousands of veterans' lives. Is that accurate?
Sir, we are certainly willing to sit down and have a conversation with this organization to see how we can partner with them.
Thank you very much for your time, ma'am. With that, I yield back.
Thank you. The chair now recognizes herself for 5 minutes of questioning. The Independence Fund will testify that in the past 23 months, their caseworkers intervened for 110 veterans who ran into issues accessing complex mental health care, and 59 of those required substance use care. In fact, in the last Congress, we passed a bill, the Brandon Act, because a veteran in my district went to the VA center, was denied care, and 5 hours later committed suicide. Would you agree that these veterans, frustrated by access to critical care, would be at an elevated risk for suicide, Dr. Campbell? Yes or no, please?
Yes, I would agree that they're at high risk, and veterans at high risk certainly would be at high risk for suicide.
And Dr. Yendi?
Yes, Chair. Congressman.
Dr. Campbell, the committee has been made aware of a policy that was supposedly rolled out internally, as was mentioned, that required that if a VISN's VA MC couldn't meet the 30-day appointment availability window, it must confer with other VISN VA MCs for VA residential substance use disorder bed availability before leveraging community care in order to keep care in-house. I certainly have experienced these complaints in my own district in Iowa. And it was also reported that 5 VA MCs must be contacted to fulfill the directive. Can you either confirm or deny this policy?
There is no policy, Madam Chairwoman, denying veterans access to community care. The CEOCs regarding residential treatment were newly established. CEOCs is a standard episode of care for community care in October of 2020. And so the process is somewhat new for us. We understand there are challenges in making sure that people are educated about the appropriate referrals to community care, but we do not have a policy denying people community care access.
Would you call these veterans liars?
No, I would not call the veterans liars. What I would say is that we need to do a better job of educating our veterans, our staff, and the community about the appropriate procedures for referrals to community care.
Well, I can certainly say, as both a physician who has taken care of veterans through the community care system, the Mission Act, and as a veteran myself, that it is unacceptable. When people report and come to the decision to obtain substance use disorder treatment, they should be addressed and acknowledged and get care immediately. And this also goes for complex mental health. And I can tell you the family of our veteran who committed suicide 5 hours after being at a VA hospital would also agree with that. Dr. Campbell, we've heard of multiple instances where veterans have been approved for a community care referral, as I said, only to have that referral overruled by administrative or other senior staff. Can you explain why a decision for a specific course of medical care, as determined between the veteran and their provider, would be reversed by an official outside of their clinical chain? And what recourse does the referring physician have when their clinical judgment is overruled, and how are you going to address this deficit?
Thank you for that question. Each case, as we mentioned, is an individual case that is a decision between that provider and the patient or veteran. And I am not aware of policies where decisions are being overturned. I'll turn to Dr. Yendi to see if he has more information regarding community care.
Congresswoman, if the provider determines that the veteran should go to the community, then that decision should be followed through. So our policies do not require that care should be provided in the VA in that instance. If there are instances, we are happy to look into it.
Let me just speak for the entire committee. We expect better of the VA medical care system. Our veterans deserve better. And through this oversight, you know, some of the comments that have been revealed are really astonishing. So we hold oversight because what's occurring at the VA Medical Center and what is occurring in referrals for community care when veterans are in need, especially complex mental health and substance use disorder, needs to be addressed and addressed rapidly. So we'll continue to ask for both collaboration and verification, as we've said, but what you have learned today should, in fact, put you on notice and on record. On behalf of the subcommittee, seeing that there are no other representatives who wish to ask questions, I want to thank you for your testimony and for joining us today. You're now excused, and we'll wait for a moment as the second panel comes to the witness table. Welcome, everyone, and thank you for your participation today. On the second panel, we have Dr. Daniel Elkins, the Chief of Staff with the Independence Fund, Mrs. Jen Silva, Chief Program Officer with the Wounded Warrior Project, Mr. Thomas Sauer, Chief Executive Officer and owner of Miramar Health, and accompanying Mr. Sauer is Mr. Brandon Dowling. Mr. Elkins, you are now recognized for 5 minutes to deliver your opening statement.
Good morning, Chairwoman Meeks, Ranking Member Brownlee, and members of the subcommittee. On behalf of Sarah Verado, CEO of the Independence Fund, we'd like to thank you for your kind invitation to provide testimony at today's hearing. As a currently serving Green Beret in the National Guard and the Chief of Staff of the Independence Fund, I've seen firsthand my brothers and sisters in desperate need be denied access to care, fall through the cracks of bureaucracy, and suffer alone with the wounds from war. It's this denial of access and subsequent isolation that often culminates in death by suicide, a death that could be prevented. This hearing could not be more timely as our casework staff have been receiving a significant number of inquiries nationwide who are experiencing frustration and hardship when seeking the most critical services for acute mental health conditions. The geographic dispersion and similarity of factors presented in many of the cases indicate that these cases are not merely anecdotal, but may be indicators of a more widespread problem for mental health within the hospital network. We would like to thank VA's VSO liaisons for their support and assistance and help with these cases. However, there is work that needs to be done. In our written testimony, the Independence Fund has provided extensive case study examples of the inconsistencies currently present within VHA care. Each of these cases involves a veteran who is in acute need and requires priority treatment for substance abuse disorder in PTSD. And these veterans were denied access to care, even community care referrals, in direct conflict with the spirit, in some cases, instance of the letter of the Law of Mission Act. And we have found that the Veterans Health Administration was unable to provide these veterans with proper continuity of care, failing to meet the most basic of industry standards. Indeed, it was not until October of 2021 that the Independence Fund discovered that VHA does not consider the access standard authorities of Mission Act when veterans are seeking help for substance use disorders. Yes, you heard that correctly. Veterans do not have Mission Act's regulatory protections for wait times, travel distance when seeking treatment for substance use disorders, as these treatments fall within VHA's Residential Rehabilitation Treatment Program. And according to the VA, this program is instead under the authority of VHA Directive 1162, which requires that VA admit a veteran seeking inpatient residential care within 72 hours for priority patients and no more than 30 days after a VA assessment for any patient needing residential care. Based on our experience, however, that is not unusual. It's not unusual for veterans to wait beyond this time limit. And furthermore, has been our observation that even after those time limits are exceeded, VHA exercises latitude to further delay access to treatment when looking for an available bed in another VA facility, even if that facility is several states away. More troubling, the Independence Fund has found that some VHA administrators or senior clinical staff overrule referrals of care for the community in spite of VA-appointed providers for the veteran. There have also been some cases where our casework team were told by an administrator that community care was not offered, and at times the administrative staff did not understand community care was even a lawful option. In certain circumstances, VA staff do not discuss community care options with the veteran without prompting or until a caseworker inquires of VA administrator or patient advocate. It is important for us all to keep in mind that many veterans do not know their full care options and have already taken a monumental step in seeking help. More work needs to be done. In our written testimony, we offer 6 recommendations to the subcommittee on how to resolve these issues that create barriers to care for veterans seeking treatment for substance use disorder and PTSD and other conditions that are highly indicative of death by suicide. But I will highlight what we believe should be the foremost priority for this subcommittee. We must ensure that all criteria for community care wait times, travel distance, and access standards under Mission Act govern VHA Directive 1162, or eliminate VHA Directive 1162 entirely and defer to Mission Act's original authorities and intent to support all levels of specialty care, including rehabilitation services. Once this goal is achieved, it will substantially improve the quality, timeliness, and effectiveness of care for veterans in acute need of treatment for substance use disorder, whether that be in a VHA provider or community care provider. Thank you for this opportunity to share with you all the struggles of our nation's heroes, and I look forward to answering any questions you may have.
Thank you, Mr. Elkins. Ms. Silva, you are now recognized for 5 minutes to deliver your statement.
Thank you, Chairwoman Miller Meeks, Ranking Member Brownlee, and the distinguished members of the Health Subcommittee for this opportunity to speak before you. Since our founding 20 years ago, Wounded Warrior Project has been helping post-9/11 wounded, ill, and injured veterans address their biggest challenges and reach their highest potential through impactful, no-cost programming and advocacy. Today, those two paths intersect to highlight how veterans who need inpatient care for mental health or substance use are not receiving access to the prompt and, in some cases, life-saving care that they need and deserve. The VA Mission Act was signed into law with broad support in the potential to provide veterans and their advocates with clear, useful, and timely information that could inform their healthcare decisions. In January 2019, VA published access standards that included limits on wait times and travel for mental health care. However, as time has passed, it has become clear that these access standards have a critical gap for veterans seeking care at inpatient programs, most specifically VA's mental health residential rehabilitation treatment programs or their community-based equivalents. As discussed in our written statement, VA's Mission Act derived access standards do not extend to these crucial inpatient mental health programs. Instead, veterans and their advocates are left to interpret a VHA directive that we've discussed. In our experience, this directive provides little predictability about the course of their treatment and their options for care along the way. Unless Congress or VA act to address this policy gap, many of these veterans will continue to face obstacles in connecting to the care they need, placing them at heightened risk for negative outcomes the longer they wait. My remarks today are largely informed by Wounded Warrior Project's Complex Case Coordination Team, or C3. This team offers a high-touch service to warriors with complex challenges that are often multifaceted and require urgent action. The team connects warriors to our internal support programs and to VA and community care treatment options, all with the goal of providing immediate assistance and case coordination. In just the last 4 years, our team has helped nearly 1,200 warriors with complex cases navigate VA and community treatment options. However, our support simply cannot reach the scale required to assist all veterans who need this heightened level of care and intervention. The team's single biggest challenge since inception has been helping veterans access VA inpatient mental health care. The lack of a consistently applied access standard has essentially resulted in no true access standard for residential treatment. Local policy variations have resulted in unpredictable referral decisions. Wait times are not uniformly calculated and can be impacted by inconsistent policies about a veteran first having to complete significantly less intensive treatment options. Staffing challenges can also limit communication and bed availability. Alternative treatment options that would result in a community or even inter-VA referrals and faster access are not uniformly accepted by VA administrators. In totality, many veterans are not accessing the care they need when they are ready to receive it. Delays in finding appropriate care in a timely manner not only fails to capitalize on the veteran's desire to change their life circumstance, but in some cases causes further damage to their mental and physical health, declines in family and social relationships, and even involvement with the justice system. And as illustrated in VA's most recent National Veteran Suicide Prevention Annual Report, substance use disorder continues to be a significant factor in veteran suicide. While the report showed overall reduction in the veteran suicide rate, subpopulations struggling with opioid, cocaine, cannabis, and stimulant disorders showed increased suicide rates. To mitigate the risks associated with inpatient care access and ensure consistent VA help throughout the enterprise, we believe that Mission Act access standards must apply to the delivery of inpatient mental and substance use disorder care. We want and we need the VA to be successful in this. Simply put, for us, VA is our most critical partner in connecting veterans to the inpatient care they need. In closing, I want to thank the subcommittee for this invitation to testify, and I welcome your questions.
Thank you, Mrs. Silva. Mr. Sawyer, you are now recognized for 5 minutes to deliver your opening statement.
Broken record here. All right. Thank you very much. Chair Miller Meeks, Ranking Member Brownlee, and members of the subcommittee. My name is Tom Sauer, and I'm honored to testify before you today. I'm a Navy and Marine Corps veteran, and for the better part of my life, I've been wearing the cloth of the nation. I'm a former enlisted Marine infantryman, a 2006 Naval Academy graduate, and a former Navy Explosive Ordnance Disposal officer. Today, however, I'm the owner and CEO of Miramar Health, a veteran-owned and operated community care provider for intensive substance use disorder and mental health treatment exclusively for America's veterans. Mental health and addiction treatment are deep passions of mine because depression and addiction killed my dad. 5 days before I graduated from high school and 3 weeks before I shipped out for the Marines in 1999, a methamphetamine overdose took his life after decades of struggle, just like so many millions of Americans suffering from our country's disastrous mental health and addiction crisis. I'd also like to point out that 4 days ago, my father-in-law died of addiction. He was an Air Force veteran. Thanks to recent legislation, thousands of veterans have enhanced access to life-saving mental health care and addiction treatment within the VA's community care network. We provided intensive, custom-tailored, world-class mental health and addiction treatment for nearly 250 veterans from a dozen VA medical centers across the western United States, typically for 30, 60, sometimes 90-plus day stays. This treatment is for our veterans who are truly suffering, in crisis, and often near death from suicide or overdose resulting from this disastrous mental health and addiction crisis. In 3.5 years, we've grown from one small clinic with 6 employees to 8 residential facilities and 1 large outpatient facility. These facilities are staffed by nearly 100 phenomenal physicians, nurses, psychologists, therapists, medical technicians, case managers, and support staff, many of whom are veterans themselves. One is sitting right to my left as well. I could not be any prouder of them. I didn't come all the way out here just to tell you all this just so I could pat myself on the back, but rather to simply convey the sincerity of our intentions and to lay out how important this challenge is. Miramar believes in our partnership with the VA by bridging both capability and capacity gaps within certain VA medical centers and in being an advocate to veterans in need, all while providing them with the highest quality of care. So in other words, we don't consider ourselves to be just another government contractor. We're partners and we're teammates with the VA. And we're here asking for your help to ensure our nation's veterans receive the life-saving care they need and deserve by helping us to strengthen that partnership. The overwhelming majority of frontline, boots-on-the-ground VA personnel we directly interact with are fantastic, dedicated, life-saving public servants. Some of these guys deserve medals and parades. There are many who deserve medals and parades. I'm here today to advocate for veterans in need to be able to access care anywhere immediately, and we can figure out that paperwork later. The current VA policy of 30 days to wait to find a bed in a given region does not meet the urgent level of this crisis. I think you've been hearing this before, recurring theme. Specifically, we've encountered several occasions where, despite community care being available for a veteran in crisis, they're either put on a waiting list for up to 30 days before receiving care when they don't have 30 minutes without becoming a very real risk to suicide or overdose. And Chair Miller Meeks, I think you've highlighted such a case. And we have cases that can highlight that as well too. I have firsthand knowledge of these suicides and overdose deaths since I've owned Miramar, so I can understand the devastation this policy can cause. We believe this issue could rather be easily corrected through a legislative carve-out for community care eligibility, as with urgent care, when it comes to urgent care for community care, when it comes to mental health and addiction treatment. This could be done by clarifying and ensuring the Compact Act is being implemented as intended, and that veterans are aware of this option for receiving care. We urge you to ensure that our veterans have access to care they need when they need it through the Community Care Network. We appreciate your consideration of this matter, and we're willing to work with you to address these issues to ensure that our guys and gals get the care they need so desperately. Thank you, Chair, and members of the subcommittee. Each of you, your staffers, and the committee staff are champions for America's veterans, so I'm exceptionally grateful to you and to your commitment to serving them and that you're holding this important hearing today. In conclusion, thank you so much for addressing these issues, and I'm more than happy to answer your questions.
On behalf of all the committee, Mr. Sawyer, our condolences on the loss of your father, and I thank you for your testimony. I will go last in the lineup of questions. I now recognize Ranking Member Brownlee for any questions she may have.
Thank you, Madam Chair. Ms. Silva, I just wanted to stay on a theme of women veterans for a minute, and I know we're talking about access. So I was wondering if you could speak at all to your experiences in trying to get women veterans the gender-specific care that they need, programs, inpatient programs, and if you could speak to that within the VA and within the community.
Well, thank you for the question. I believe the women-specific care, it adds an element that complicates this already kind of urgent action approach to this. We have a very short window for care. If a veteran comes to us in needs that, we're talking specifically mental health and substance use disorder, the co-occurring with either military sexual trauma makes them at a heightened risk, as we talked about in the previous panel, for this. I have a vignette that I think is a pretty interesting one where a female veteran was trying to get care for MST and substance use disorder, so co-occurring, and the opportunities were not available. They were available in that community care network area. Unfortunately, in this situation, the VA said it seemed too resort-like, and were not able to get her into that care. They did not allow for that. And so what she did, but they did have an inter-VA option, and she moved her entire family across a couple states in order to get into that care. She was into VA care, and I think, in my experience, once they're in the care, so all those barriers of maybe females not being comfortable, once they're in there, it's been very productive, and the outcomes are fantastic. So we've got to work on, it doesn't have to be that difficult where you've got to move across states. Maybe it had to work in this situation. I think we can do better, though.
Well, I think it's true for men as well as women, but I think for particularly women, I think you just highlighted one of the, I think, big obstacles to access, and that is a woman to get the proper resources and treatment that she needs many times has to travel outside of her state in order to receive that within the VA. And so, what does a woman do with her family? All of that. It becomes a tremendous burden for them to leave family, to leave responsibilities in order to get the appropriate treatment. So I feel like we need to address some of those issues as well, and as a consequence, we need more, I believe, more gender-specific programs for women. I wonder if you could just comment a little bit about, and I know we're talking more about access, but just in terms of your experiences with getting referrals inpatient within the VA and within the community. Can you speak to, it's my sense that when I've spoken to people, once they get into the VA and inpatient care, it's pretty good, and the success is there. But can you talk a little bit about quality of care compared to inpatient VA versus community care? Can you give any kind of conclusions?
Well, ma'am, I actually agree with what you said. Once they're into care, whether it's in the VA and in the community, it has been very positive overall. It's the connective tissue in order to get them into that care is lacking, and they are willing. Oftentimes they have to go to a less intensive program before even if the clinical decision is that they need this inpatient approach, it needs to be quick. That window of opportunity, especially when we're talking about these complex cases, most of them co-occurring or the substance use disorder, it's a really short window. Yep. You've got to act, as everyone would agree. So you have to have that availability. And there's a shortage, et cetera. So if the community can provide that, then that's the best way to go, in my opinion, because ultimately the veteran has a positive experience. It's still a VA referral. So I think from a customer perspective, it actually keeps your customer, if I can use that term, happy with the overall care, even if it's not within the VA medical center. I know back to the military sexual trauma or women-specific care, we have found within our Warrior Care Network, it's extremely important to many of the women that are served through our intensive outpatient program that they receive it outside of the VA or outside of maybe if they're still active duty. So that is a gigantic barrier to care. And so if that is the best option for that female veteran, then let's do it. And we have VA liaisons there that can get them back into VA care. So it's really not outside, it's just the connective tissue is a really positive experience for that veteran.
Thank you. I yield back.
Thank you, Ranking Member Brownlee. I now recognize Representative Luttrell for any questions he may have.
Thank you all for your service to this country and your continued service to our veteran community. I really appreciate that, and sir, I'm very sorry for your loss. Given the previous testimony, the previous panel's testimony, Mr. Sauer, can you just explain to us as a veteran why it is you do what you do today?
Well, thanks for the question, Mr. Luttrell. I found really no higher calling than helping fellow service members. That's what it comes down to when it came down to all this. And also I realized that there's a bigger crisis especially you two gentlemen up there on the dais, that we've probably lost more friends and colleagues to suicide and addiction than we did on the battlefields overseas. And I saw this as an incredibly growing problem. And it was the opportunity for a Tri-West contract was presented. I didn't know this was something that was even available. And I look at this phenomenal opportunity that serves this growing dramatic public need. And when one of my partners, who's my Naval Academy classmate, and I work with folks like Mr. Dowling here from the Special Operations Community, what a phenomenal group of people, and just to absolutely save lives. I can tell you right now that, as a former Navy OD officer, I spent a long time in uniform, that the work that we're doing here today is far more valuable and to the nation and to the country and frankly for the world at large than anything I ever did wearing the uniform.
Congressman Van Orden brought up a very valid point. It said the Suicide and Prevention Office in the VA has been in place for 34 years. And my question that I didn't get to ask them was, has the suicide rate gone up in those 34 years? And it has, absolutely. So I think that lends itself to the efforts that this panel is making to protect our brothers and sisters in the veteran space. If there were one change that you could make that would increase veteran access to life-saving substance abuse and mental health inpatient care, what would that be?
I think that's a pretty simple one right now, is that to change that wait time from 30 days, when they don't have 30 minutes, ordinarily I'd suggest 24 hours, but you know what, to kind of be, to be a little understanding of the VA, 72 hours, that's one business day. So when a veteran shows up to their VA provider in a mental health or addiction crisis, that the VA is, their standard must be that they put that veteran into a bed, get them off the X, so to speak, because we don't know exactly the severity of the need of care, get them off the X, and they have the opportunity to be in a residential treatment program, whether or not that is in a in-house VA facility. And if those facilities are full, not available right away, then you get them into a community care facility within 72 hours, one business day, preferably 24, frankly. But if we can do that right there, because obviously, one, we need to be able to ramp down the level of care as far as if somebody has to wait 30 days, but then they can do telehealth, that's ramping up the level of care. You need to get them off the X right away, get them into a highly intensive level of care, and then you can assess and start ramping down those levels of care. However, I would say that's what you got to do right there. Just immediately get them off the X in that care, 72 hours, and I think that's it right there. I mean, in a simple word, is not 30 days. You've got 72 hours, whether it's in the VA or outside with community care.
For us on the panel, and having dealt with the VA at multiple levels, is it in your professional opinion that the referral process is failing at a lower level or at the higher leadership level?
It's the higher level. Absolutely. It's not the social workers we deal with. I've encountered many who have told me, over the phone, told people like Brendan over the phone as well, or even over email, saying this program looks fantastic. I would love to write you a referral. Instead they would say, however, the residential rehabilitation care has a different Mission Act eligibility criteria than other specialty services. And then they cite 1162.02. And when I spoke, in that particular case, I took that particular veteran on scholarship. He was a retired Marine, spent a long, former infantryman, and we took him on scholarship. We also have a former Navy SEAL who is in our facility today on scholarship as well because he was denied care and denied access. But we saw we had to do the right thing, and we know when I speak to these social workers, nearly every single time, they're the ones who say, we would love to be able to refer them, but we can't. They won't let us.
If you don't mind, I'd like to circle the wagons and get those names and the positions they hold so I can address them directly. I yield back.
Thank you, Representative Luttrell. I now recognize Representative Van Orden for 5 minutes.
Dr. Campbell, I see you in the back there, and I want to thank you for staying here. Just so you're aware, I think, Brendan, you're an enlisted guy, right? Yeah, you didn't go bad like like Sauer there?
Yes, I was.
Yeah. Noted. Ma'am, so as enlisted people, we need to make the rubber meet the road. And so although those questions appear to be harsh, they're for a very specific reason so that we can quantify a problem and then move forward. Our purpose here, my sole legislative agenda as the chair of a subcommittee for Veterans Economic Opportunity is to prevent veteran suicide. So I thank you for staying here. I appreciate that greatly. What I've noticed, gentlemen and gentlewomen, is that the issue is not with the Veterans Administration in many cases, it's with the Department of Defense. And what I'd like to ask you specifically is what is your access to the Transition Assistance Program? And we'll just start with Mr. Elkins, the Green Beret.
Well, as an enlisted guy, it's always a pleasure to be in the company of other enlisted.
Okay, I didn't realize that. I thought you went bad too. Go ahead.
Working with the Transition Assistance Program at many levels, having gone through it multiple times, we'll have to go through it again in the next several months as I'm about to transition out of my role to deploy for the third time in the last several years. There's definitely gaps that need to be addressed.
So let me ask you something. Specifically, does your organization have access to the Transition Assistance Program so that you can speak to active duty service member as an upstream solution to prevent them from committing suicide and having drug and alcohol addiction issues after they retire?
Yes.
You do?
Yes.
Okay, ma'am? Ms. Silva?
No, we do not.
You do not? Okay. Mr. Sauer?
No, sir, we're not. We're dealing usually directly with VAs, and by the time a veteran comes to us or we're made aware of a veteran that in need, they've already gone down. They're already in a bad spot.
And then, Brendan, what class are you in?
I was in Bud's class 242.
New guy. With you? Okay. When you went through the Transition Assistance Program, were you made aware of any of these external organizations that may help you bridge the gap from being an active duty service member to becoming a productive veteran?
No, I was not. My transition assistance program experience was unremarkable. I didn't really pull anything from it.
Okay.
Of use.
And then just for everybody across the board, what do you feel like you have access to the Department of Defense and ready access to the Veterans Administration on a co-equal basis? Because we have to get upstream solutions. So do you guys have points of contact that you can call? Do you feel like the DOD is responsive to your guys' inquiries? And if you needed to, can we help? If you don't, can we facilitate that for you so that we can start up here and then work our way to the veteran status?
We do have access. In some cases, it's very timely. In other times, we will use you in your office for assistance.
Okay, that is absolutely open at any time. Ma'am?
I would say we've developed on the DoD side, we've developed relationships with different commands. We have heavy involvement in Alaska due to the increased suicide rates there, and we've been able to be part of that solution, working with the community there. And then it's very command related, and that's the difference, in my opinion, between DoD and VA. We have, most of the warriors that we serve are already on the veteran side of the equation, and so our bigger contacts are with the VA, but we certainly would love more collaboration with the transition piece of DoD.
Okay, excellent. Mr. Sauer?
Miramar's contracted with Tri-West Healthcare Alliance, which currently has the sole contract with the Department of Veterans Affairs, so we have no formal relationship with DoD. However, as you may be aware, Tri-West Healthcare Alliance won the contract for TRICARE West, so we will, beginning next year, it's my understanding, we will be able to treat active duty and their families, which we look forward to. We're close to Camp Pendleton. There's a large population of active duty there. And we welcome the opportunity to strengthen those relationships for that transition.
Okay. Hey, my time is expiring. I just want to tell you that my office is yours. I know that there's no one on this panel, Democrat or Republican, who is unwilling to step out to make sure that we can facilitate your organizations to work in conjunction with Dr. Campbell back there to help prevent veteran suicide. So with that, God bless you and thank you for your work very much. Ma'am, I yield back.
Thank you, Representative Van Orden. I thought about removing your time because I take offense as a former enlisted who became an officer.
Same here.
Mrs. Silva, who is a West Point grad, that I did not go to the dark side when I got pinned my lieutenant bars. I now yield myself 5 minutes for questions. This is a very sobering hearing in many ways. And let me just say that as a veteran and as an ophthalmologist, and I did both care active duty military, I did Veterans Administration care, I was an assistant professor in academic medicine and as well as private practice. And I was an ophthalmologist, but let me just say that when I would get calls from a patient for a red eye, I would see that patient that same day. That's a red eye. Nowhere near the gravity of what we're talking about now. And that was my personal standard. It was not a standard imposed upon me by an insurance company, by the institution for which I worked, nor by members of Congress. Mr. Elkins and Mr. Sauer, in both of your testimonies, you mentioned being made aware of a VA policy stating that the VA has 30 days to place a veteran with substance use into an inpatient mental health residential rehabilitation program when working cases for veterans in crisis. Can you explain further your experiences with the VA when policy is not adequately or inaccurately conveyed?
Thank you for that question. 30 days is too long to ask a veteran to wait on the availability of an RRTP facility or care in the community. In a 30-day period, the risk of suicide or destabilization can drastically increase. So we recommend a clinically sound, lesser number of days because PTSD in conjunction with SUD require swift intervention and services. Additionally, in some cases, veterans lack trust with the VA based on past experiences. And the mere fact that you have to go through an RRTP facility first and fail, and then afterwards go to the community care needs to be addressed.
Thank you. Mr. Sauer, I'll just kind of dovetail on that and then go to you. Both of you are in your work with veterans. Have you heard anything about a recent direction from the VA MC that if they can't meet the 30-day appointment availability, they have to confer with other VISNs, they have to try to get them into care at another location, or that 5 VA MCs must be contacted to fulfill the directive? Have you all heard that?
Yes, we have. As a matter of fact, Mr. Dowling to my left is the one who directly dealt with that after speaking with a VA-MC therapist who was one who also managed many community care referrals or made the consults that would later become referrals. Brendan can definitely speak about it in more detail if you have questions, but it was that if a VISN's VA-MC, it went into effect on, I think, October 1st is what they were told. We were told this verbally. This was not in a writing or policy. That if a VISN's VA-MC cannot meet the 30-day appointment availability window, it must confer with the other VISNs for bed availability before leveraging community care in order to keep the care, quote, in-house. He further reported that 5 VAMCs must be contacted in order to fulfill the directive. He advised this new policy would highly impact referrals out to the community. Is there something else you want to add? If I may, is that right, to Mr. Dowling? It's okay if not. Understood.
Have you experienced the same thing?
Yes, we have experienced the same thing in multiple cases over the last several months. As of January, we've seen a significant increase in the amount of cases we're seeing where there are unnecessary delays.
Thank you. It's just surprising then that our bureaucracy hasn't heard the similar thing. Mr. Sauer, we often hear that the VA care is the best care because those who work at the VA understand the veteran. And I'm going to refer to a community organization I have in one of my largest cities in my district in Davenport, where an entirely volunteer veteran organization assisted a veteran who had not seen their family or come for any kind of care for 20 years, had not seen their family. The veteran showed up there to this total voluntary organization, no one taking a salary, and contacted his family for the first time in 20 years. How does your experience and the experience of your staff, such as those with Mr. Dowling's background, equip you to serve our nation's veterans?
It's a big question, ma'am. I would say that we're incredibly honored for this opportunity to do this. I will say that there's nothing that's more rewarding, and I know that when Brendan joined the team last year, he saw the mission we were doing. I mean, he can speak for himself on that one, but most certainly we go pretty far out of our way for a number of cases. We've taken for what it's worth as well. When we have cases where a veteran has, for any number of reasons, but usually due to the reasons that we're here for which we're here today, they're unable to get care, we take them on scholarship. Now, I still have nearly 100 employees. I have to make payroll, keep the lights on. I can't do that continually, but I'm happy to do that when it, in certain situations. We've done that about 7 or 8 times that I can think of in the past year or two. And we just do it because it's the right thing to do. That's it.
Thank you, and I yield. Ranking Member Brownlee, would you like to make any closing remarks since I see no other members here?
Well, yes, thank you, Madam Chair, and really thank you very much for having this hearing. It's very much an important hearing, of which I still feel like we need to do even a deeper dive on it to really get down to the bottom of things. And I really thank this panel for your testimony, and this is one of these hearings where I wish we had panel 2 first and the VA second, because there's so much that you have raised that now I would like to ask the VA. And I think there is clearly a disconnect between the VA's testimony and your testimony, and we need to get to the bottom of that. I have a feeling that some of the problem has to do with how VA really addresses access and how they account for access, and missing some data points perhaps. But I do want to acknowledge that what I'm hearing from panel 2 as well is that the quality of care within the VA once a veteran gets into the VA is very good. So I want to, applaud the VA for the quality care, but the access piece, and when we're talking about suicide and other kinds of things, that getting, when someone is in crisis and they come to the VA or come to any of you, they need to be, if there's not a bed, they still need to be in a room. They don't get to leave the hospital at that particular point. They are in the care of the VA, and never should a veteran walk out of that VA in crisis. So I think, clearly something has to be done here around these access points. And Mr. Sauer, too, I want to congratulate you, too, on the quality of community care that you're providing in your area. So we thank you for that. And again, my condolences to you with regards to your father. And with that, I will yield back.
Thank you, Ranking Member Brownlee. I'd like to thank everyone for their participation in today's hearing and for the productive conversation. I would like to especially thank our most recent panel for submitting their witness testimony in a timely fashion so members of Congress could read it. As a veteran, as a doctor, as a former director of the Department of Public Health, and someone who was very active in mental health and substance use disorder, it's one of my top priorities, and I know the same goes for my colleagues on both sides of the aisle, to take care of all veterans and to ensure that they have timely care, especially for those who are struggling with complex mental health issues and substance use disorder. No one here on this panel, the witness up on the dais today, has impugned the quality of care delivered at the VA. But the most important metric, not hundreds of metrics, the most important metric of success is whether the suicide rate has gone down. And unfortunately, it has gone up. No veteran should be turned away when a decision is made to seek help. I look forward to working on these issues. I look forward to working with my colleagues on the other side of the aisle and many more with the department, stakeholders, and my colleagues on this subcommittee. The complete written statements of today's witnesses will be entered into the hearing record. Questions will be submitted, and we will ask that they be responded to in a timely fashion. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and include extraneous material. Hearing no objection, so ordered. This meeting is now adjourned.